So much, sir. Very good afternoon, everyone. Talking after Dr. Archana ma'am for type 1. So it can be a bit different outflow of events totally, but let's see. So we have been given the responsibility of talking about the adjunct molecules that we may or we should or we could. So that is the question. So can we use them? Answer is yes, definitely we can use them. Should we use them? Then that is individualized. And what is the result and the response? So let's see, and why and where. But all through the slides, remember one thing, we are talking of adjunct therapies. We're never talking of replacing insulin anywhere. Insulin is and will remain the mainstay of management of type 1 diabetes. So we are talking about replacing adjunct therapies or supplementing insulin with SGLT2I or GLP-1 RA. So let's see. As we all know that the data is increasing in spite of everything, the awareness is increasing, educational plans are increasing, but at the same time, the burden is also increasing. So we have around 1.5 lakh children added every year. And as Madam was rightly talking, we are increasing our technology aspects, we are increasing our knowledge in all the spheres. We are now using CGM very frequently. We have monitors, we have SMBG, we have the pumps. But in spite of everything, the T1D exchange registry says that we are still failing to meet the targets. We are still not to the mark, and the HbA1cs are still high in most of our children. So, where are we failing? What are the unmet needs of type 1? In spite of being on insulin, we very frequently come across hypers, glycemic variability. And I think everybody, being a physician here, will agree with me that it is the blood glucose level that affects the endothelium, the vascular endothelium I'm talking about. So the micro and macrovascular complications are bound to happen to these children if the sugars are not controlled. Because ultimately, the level of blood glucose decides the endothelial damage, not whether this rise is because of insulin deficiency or because of insulin resistance. It is the absolute value of blood glucose that will damage the endothelium. How the type 1 is not present with micro and macrovascular complications, whereas type 2 has at the onset, at the clinical presentation coming to you with complications. That can be explained by the phase of hyperinsulinemia, which is present in type 2, but we are missing in type 1. So there is no insulin resistance, so there is no initial phase, a hidden subclinical phase of hyperinsulinemia. So probably that is the reason that we explain that the micro and macrovascular complications are not present right from the start. But eventually, after 5 years, we start screening our children also for all the complications. So though insulin remains the mainstay of therapy, why we have started using type 2 molecules in type 1? What are the unmet needs? Because most of the studies with the newer molecules, the GLP-1 RAs or SGLT2I, the CVOT trials, they've all been done in type 2. But can we translate their non-glycemic benefit to our children? That is the question. So there is a strong link between hyperglycemia and the vascular damage, that is the CVDs. And what is this link? This link stems right from the glycemic variability causing atherosclerosis, atherogenic properties of insulin by the MAPK pathway maybe, giving rise to the various inflammatory markers, giving rise to the reactive oxygen species, leading to the endothelial damage, ultimately causing all the micro and macrovascular complications. So, type 1 diabetes will also benefit from the tight glycemic control. That is understood. And this tight glycemic control, if we are not able to achieve with insulin alone, can we use the adjunct therapies? So, if yes, what are those? These adjunct therapies can help by reducing weight if the weight is on the higher side. They can help by decreasing the probability of lending our children into hypoglycemia. They can help by decreasing the dose of insulin, maybe. So, the molecules which have been extensively studied as adjunct are metformin to begin with, and probably most of us who are avid practitioners of type 1 must have prescribed metformin to some of our children. If I my personal experience, if I say, most of my girls, if they are around puberty and if they are obese and they're also having PCOS component, we try to add a little metformin. Again, the children who are around puberty or teenagers or boys above 18 and they are gaining weight and they say we are always very hungry, the appetite is very high, we add a little metformin, obviously. But we have data now from DPP4 also, and we have the data with GLP-1RA, interestingly, which is a very interesting molecule, and of course the SGLT2I, which has a bad reputation of coming in the market with euglycemic diabetic ketoacidosis. As we all remember, that SGLT2I was extensively used in type 1, but then it was withdrawn and banned because of the increasing incidences of euglycemic diabetic ketoacidosis. So first, metformin. So, how does metformin actually work? Metformin will act as an insulin sensitizer. So, it will act at the hepatic level by decreasing gluconeogenesis, and it will help in promoting glycogenesis. So, it will decrease your fasting blood glucose and it will help in the further transmission or translocation of the GLUT4 receptors to the cell membrane and improve your glucose utilization. So exactly the same way, metformin has been tried in type 1 children. It helped in bringing down the body weight, but HbA1c levels, disappointingly, were not affected. So from here, we had the removal trial, that was a drug trial on type 1 population. There was some reduction in body weight, there was some reduction in LDL cholesterol, but HbA1c did not improve much. Then we moved on to the DPP4 inhibitors. DPP4 inhibitors are the incretin molecules. They help by increasing the endogenous GLP-1s. So by prolonging the action of endogenous GLP-1, by inhibiting the DPP4 enzyme, these molecules helped in bringing down the insulin requirement by some 20 units. But besides that, they did not help much, so they are not very frequently recommended. Then the molecule which is in question, that is GLP-1RA. Now, GLP-1RA, the first molecule to be tried was exenatide, that came by the name of Byetta. So exenatide was prescribed twice a day, but it did not reach up to the expectations. Then came the liraglutide. Now, how does GLP-1 actually help? Let us have a look here. In normal population or in type 2 population, the GLP-1RA has multiple roles. At beta cells, it will help in improving the survival and improving the insulin secretion. Alpha cells, it will bring your glucagon level down. At hypothalamic level, it will increase your satiety. At gastric level, it will decrease your gastric emptying. Out of these, all the concepts, if you can see this part, this here, this is the image of a type 2. Because if I take out the beta cells, because beta cells are not there in type 1, my type 1 children will have no beta cell. So other than the role on beta cells, the remaining action, that is the action on alpha cells by bringing down glucagon, the action on the gastric emptying, the action at the hypothalamus to improve satiety, the remaining effects of GLP-1RA can still be utilized. So GLP-1RA was recommended in type 1 children. And it does work by decreasing all of these except the beta cells. So there was the adjunct 1 trial with liraglutide, and after the adjunct 1 trial, lira started having a place in the type 1 prescriptions. The magic trial did not work much because with the exenatide, there's some noise levels. Okay. So lira, the adjunct 1 trial, here it was this population where liraglutide got some place in the management of type 1. Now this is the data from the CGMS trial, the CGMS data, and you will find that the time in range post GLP, the TIR, the time in range was much better in the type 1 population. And now this is the entire meta-analysis, data analysis of the GLP-1 studies, which have shown that GLP-1 in type 1 does help in subtle reduction of HbA1c, somewhat reduction of fasting blood glucose. Mainly, it is having effect through reduction of body weight, decreases the incidence of hypoglycemia. Ketosis is not much of a problem with GLP-1 RA, but the side effects, that is nausea, vomiting, and diarrhea, they are known to happen. So we have to counsel the patient for that, of course. Then comes the newest molecule that we are discussing, that is SGLT2I. Now, SGLT2 inhibitors, mainly the blood glucose, which is filtered through the glomerulus or the Bowman's capsule, that entire glucose is absorbed back into the system by the SGLT2 receptors in the proximal convoluted tubule. Now, somehow, if I can stop that, that is SGLT2 inhibitor, the entire glucose will be lost in the urine. So that is very good. We can do that. Then we have the dual blockade, that is the sotagliflozin, which work at the SGLT2-1, so dual blockade of SGLT2-1, which will prevent the absorption of glucose in the intestine, at the same time block the reabsorption of whatever glucose gets filtered from the kidneys. So it's a dual blockade. So sotagliflozin has been the most extensively studied molecule in type 1 and it has given good results. Evidence says through the DEPICT trial, the EASE trial, and the In Tandem trial. So DEPICT trial was done using DAPA, EASE trial that was done using EMPA, and the Tandem trial using sotagliflozin. All the three studies have given the similar data that there is some reduction in HbA1c, somewhat reduction in body weight, but all the studies have a slight increase of euglycemic diabetic ketoacidosis. Now, why does that happen? The lesson learned is that these molecules are good, they can be used, they will help in addition to insulin in reducing HbA1c, in reducing glycemic variability, in reducing body weight, in reducing the dose of insulin, but at the same time, they will put our children at the risk of euglycemic diabetic ketoacidosis. So, why does that happen? And what do we do about that? First, let us see why it happens. Number one, it is causing glycosuria, so increased urinary volume causing dehydration. As we just learnt in Dr. Archana's lecture, that dehydration is makes the child vulnerable to diabetic ketoacidosis. So there is loss of volume. Then there is increase because the blood glucose is decreasing, so the insulin is anyways not there, but because the glucose is decreasing, the plasma glucagon starts rising. There is increased lipolysis, and because of lipolysis, there is increased fat metabolism, and there is ketogenesis or ketone body synthesis. So this is how the child lends with euglycemic diabetic ketoacidosis. So what do we do about it? So for that, we have certain international guidelines in place. We have the NICE guidelines. These guidelines give you a very clear picture when to add adjunct therapy, specifically SGLT2I. So the child should be above the BMI. The child should still be on insulin and the dose of insulin should be more than 0.5 units per kg body weight. That is the point where the child should have a serum ketone level less than 0.6 and a properly functioning kidney. That is no sign of nephropathy. And the child should be above 18. If these are the criteria met, there's a green signal, you can go with SGLT2I. If any of them is troubling you, please stop, don't prescribe SGLT2I. So these are very clear guidelines given by NICE and accepted by ADA also. Still, if the patient or your child is on SGLT2I and develops the slightest sign or a marker or any warning sign of diabetic ketoacidosis, immediately stop. So stitch protocols, number one, stop SGLT2I. Ensure insulin is being administered. Make sure the child is consuming carbohydrates. Keep the child hydrated. So the stitch protocol has to be followed. So now we are meeting the two goals. One is we are meeting the HbA1c goal. We are keeping our child in the time in range. Other than that, the second goal of cardiovascular safety and health is being matched. There are no CVOT trials in place in type 1 children. So please remember, we don't have the CVOT trial, but we have the CVOT trial of these molecules in type 2 population. So we can apply that knowledge to the type 1 children, and these molecules can be used in type 1 children or in type 1 adults to ensure the vascular health. So now it is a time to debate. Are these molecules as good in type 1 vascular endothelium as in type 2 vascular endothelium? So now this is an open debate. First, we need to establish, is there a difference in vascular endothelium 1 and type 2? That's a topic altogether different. NICE guidelines I have already taken you through. This is again ABCD guidelines, which are again recommending, they are just backing the NICE guidelines. I am rushing because the time is over. So the take home message for the evening is, whatever, there's a lot of data, a lot of studies are there, but the take home message that I will tell you today is, there are all so many studies with all these adjunct molecules. Okay, so the take home message is that SGLT2I and GLP1RA, they can be wisely, judiciously given as adjunct therapy to insulin in all our children with type 1, but you need to manage and maintain a fine balance. It's just like walking on a rope. We need still more data, more trials, and more knowledge on this topic. We are still not very apt with it, but yes, the things are in place and they are rolling. Let's collect our own data and then we can talk about it.